This poster is based on ethical and clinical issues identified in a real case involving a restrained patient who experienced a fatal deterioration during transport. The purpose is not to retell the case, but to translate key findings into paramedic practice using clinical evidence and ethical reasoning. Restraint is frequently used in pre-hospital care during behavioral emergencies, including mental health crises, intoxication, or patients with an altered level of consciousness. However, clinically, restraints can directly affect ventilation through chest restriction and positioning, increasing the risk of positional asphyxia or hypoxia. From a physiological perspective, reduced movement or agitation should not be interpreted as improvement, as patients may be transitioning from agitation into respiratory compromise or decreased consciousness. Ethically, this involves duty of care, harm avoidance, and patient advocacy, particularly when deterioration may be subtle or rapid. These events also significantly impact public trust in paramedic services, especially when outcomes are potentially preventable. This educational tool translates those findings into practical paramedic guidance. It reframes restraints as a clinical intervention requiring continuous reassessment, not just scene control. It highlights key risk factors, such as prone positioning, chest compression, and decreased respiratory effort, which are associated with impaired ventilation and reduced oxygenation. It also emphasizes that a sudden decrease in resistance or agitation may represent hypoxia or loss of consciousness, not clinical improvement. Actions such as repositioning the patient are included because they improve ventilation mechanics and reduce the risk of a positional asphyxia. Continuous monitoring of airway, breathing, and level of consciousness is essential because deterioration in restrained patients can occur rapidly and without obvious external signs. Another important factor this tool addresses is the reality of scene pressure and cognitive overload in paramedic practice. In high-risk acuity situations involving agitation, violence risk, or multiple responders, clinical judgment can become narrowed toward immediate scene control rather than ongoing physiological assessment. This is where deterioration can be missed, not necessarily due to lack of knowledge, but due to competing priorities, stress, and task fixation. In restrained patients, especially, there can be a false sense of security once the patient is physically controlled. However, physiologically, this is often the exact point where risk increases due to restricted ventilation and increased oxygen demand prior to restraint. This is why structured reassessment is critical. It creates a deliberate pause in care where airway, breathing, and level of consciousness are actively reevaluated rather than assumed to be stable. In practice, this means paramedics must actively resist the assumption that controlled equals safe, and instead maintain continuous clinical surveillance, even when the scene appears to be stable. This tool can help to improve paramedic practice by strengthening early recognition of respiratory compromise and reinforcing structured reassessment during transport. It supports safer clinical decision-making in high-stress environments where cognitive overload may lead to missed deterioration cues. It also reinforces the paramedic's ethical responsibility to advocate for patient safety, including intervening when restraints become unsafe. Ultimately, it bridges ethical principles with evidence-informed clinical practice. One final important aspect of this topic is the role of paramedics in real-time ethical decision-making under uncertainty. In practice, paramedics are often required to make rapid decisions with incomplete information, limited time, and high emotional intensity on scene. This means ethical principles are not applied in isolation, but rather in dynamic environments where safety, patient behavior, and crew safety all intersect. In restraint situations, specifically, there is often tension between ensuring scene safety and maintaining patient physiological safety. While controlling a violent or agitated patient may feel like the immediate priority, this cannot override the ongoing responsibility to protect airway and breathing. This creates an ethical balancing act between autonomy, promoting patient well-being, and preventing harm to the patient, especially when patients are unable to participate in decision-making due to altered mental status or intoxication. A key point is that ethical practice in these situations is not just about making perfect decisions, but about maintaining continuous reassessment and the willingness to adjust actions as the patient condition changes. This includes recognizing when an intervention that initially seemed appropriate, such as physical restraint, may need to be modified or reversed if the patient's physiological status begins to deteriorate. Ultimately, this reinforces that ethical paramedic practice is not a single decision point, it is an ongoing process throughout patient care. This tool is informed by pre-hospital care standards and literature on restraint-related respiratory compromise and positional asphyxia in emergency medicine. In conclusion, this informational poster transforms a preventable adverse outcome into a practical learning resource. By integrating clinical evidence and ethical reasoning, paramedics can improve patient safety, reduce preventable harm, and strengthen public trust in pre-hospital care.